Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. Today we are going to cover one of the most important topic, very high yield, which is chronic kidney disease. You guys see my screen? Yeah, you do. All right. So chronic kidney disease is very high yield. Probably you get a few questions in the licensing exam. So I do really need you guys to give your 100% focus for this lecture. And I'm pretty sure once we are finished, you wouldn't be having any issue dealing with chronic kidney disease question. All right. So what MCCQ1 test in chronic kidney disease? So the most important thing, these are the things that they want to test you and they expect you to know. So how do you confirm a chronic kidney disease? First of all, when we call it chronic, the chronicity is supposed to be more than 3 months and albuminuria. So if you see a GFR less than 60, a GFR less than 60 for more than 3 months, and the patient also has albuminuria, then you have the diagnosis of chronic kidney disease. Remember, if you have the GFR less than 60 due to an illness, for example, the patient has gastroenteritis and it just drops mildly, let's say it is 55. So it is less than 60. Is it chronic kidney disease? No. Why? Because it just dropped. This is called acute kidney injury. It might recover. In most cases, it will recover. It will go back to the normal level. But if it lasts more than 3 months, then it is called chronic kidney disease. That's the most important thing about the chronic kidney disease and acute kidney disease. So in this scenario, how do they test you? How do they test you based on this definition? So they gave you a scenario, let's say 68-year-old male had a gastroenteritis, diarrhea, vomiting, this and that. And now when you check the GFR is 55. So what is the diagnosis? Is it chronic kidney disease? No. What is the best next step? That could be a very important question. And I really want you guys to pay attention here. So what will be the next best step for you guys? So the best next step is to check the GFR in 3 months. Why? Because if the GFR is still low after 3 months and they're looking for something like chronic kidney disease, then yes, it is chronic kidney disease. Okay? You might get a case like this. What will be the next step to see if the patient has chronic kidney disease? I recheck the GFR in 3 months. Why? Because I need the chronicity present. A stage using the CGA. We will talk about the CGA in details. So, and interpret risk albumin drives risk. Pick correct screening test. So what is the correct screening test for the chronic kidney disease? If you have somebody and you're suspecting that the patient may have chronic kidney disease, how do I do the screening and the diagnosis? Remember, the ACR, albumin creatinine ratio, is not only the screening, it is diagnostic and monitoring as well. So if they're asking you about the screening, ACR. If they're asking about the diagnose, also can be used as a diagnostic tool. And if they're asking you about the monitoring, so it can be used as both and all. Okay? Screening, diagnose, monitoring. So they want to really know that you know not using the dipstick for screening of the chronic kidney disease. Why? Because this is a common mistake being done by IMGs. So that's why I made it red, and I'm emphasizing on this, not to make this mistake, because they will put it as one of the options and they want to trap you. Okay, start kidney protective therapy and state monitoring. So how do we protect the kidney? If you happen to have a patient and the patient has kidney injury and you want to start, for example, let's say you have a patient 68 years of age and the patient has 145 systolic over, for example, 95 diastolic, and the patient has abnormal GFR, how do you control or prevent further damaging of the kidney? Obviously, we have to start something which is called cardiorenal-protective agent, which is the ACE inhibitor, right? So the ACE inhibitor is preventing further damage of the kidney. That you have to know that I need to start it not only to control the blood pressure, I need to protect the kidney and the heart. Okay, that's another thing that they want you to understand when you are dealing with a chronic kidney disease. Recognize referral triggers and plan early. So referral, you have to know when should I treat the patient, at what stage. We will get into that in the next slide. When do we have to treat the patient and when do we have to refer the patient? It's very important. And when do we have to, treatment and referral. Based on that, then they will decide whether they want to do the transplantation or whether they want to do the dialysis. But for us and a general clinician, we need to know that at what stage do we have to treat, at what stage it is beyond our limitation or beyond our scope, so that we have to refer it to specialists. Let them decide. That's important, which we are going to talk about. I think we have it here, right here. So manage complications. What are the most common complications that they want you to know and how to manage it? So the complication would be anemia, chronic kidney disease, the bone the disorder or the abnormality of the electrolytes like calcium, vitamin D, and a parathyroid hormone, and also acidosis and hyperkalemia. And out of all of them, most commonly tested complication of chronic kidney disease is the hyperkalemia. And we will talk about that, how we can take care of those complications one by one. So now common exam traps, how they trap you, how they trick you in the exam. So labeling chronic kidney disease from one mild low GFR. So if it happens that your patient has mild GFR, mild low GFR, just after an acute illness is not chronic. Why? Again, the duration has to be more than 3 months. And as soon as you see the GFR less than 60, you just directly go for the chronic. No, it has to be less than 60 and it has to be more than 3 months. So the GFR less than 60 for more than 3 months is called chronic kidney disease. But remember, not only GFR, but you have to have albuminuria, which is a marker that shows kidney damage. Okay? Urine diabetic protein instead of urine ACR. So it means that they are going to use this as an option and ask you what is the best screening test for chronic kidney disease. And the first option will be, for example, urine diabetic. And the second will be ASR. So obviously, don't go with this one. Okay, they trap you. Not rechecking creatinine and potassium after using ACE inhibitor or the sodium glucose co-transporter 2, which is used for that. It is also cardiorenal-protective. So they might ask you, other than ACE inhibitor, what is another agent that's used to protect the kidney and the heart, especially in somebody who is diabetic and has chronic kidney disease? It will be this one. Okay? Not only the ACE inhibitor and ARBS is considered cardiorenal protective, the second option is this one, and they will test you on this one, especially if you have a diabetic, especially you have diabetic chronic kidney disease, especially if you have chronic patient with a chronic diabetic patient with a chronic kidney disease with obesity or overweight, because it also helps you with losing weight. So these three things, remember. So it is very important to remember that if you start the ACE inhibitor, as I mentioned before, you have chronic kidney disease, and then the patient has hypertension. So you need to control the blood pressure. At the same time, when you're controlling the blood pressure, you have to protect the kidney and the heart at the same time. So when I start the AC inhibitor, probably they give you a scenario. Like you start the AC inhibitor, what is the best next step? What is the best next step? For example, they give you a bunch of options, and one of those options will be check for creatinine and potassium. And that will be your right answer. Why? Because the ACE inhibitor, as soon as you start it, the creatinine goes up a little bit, mildly. It doesn't hurt the patient. That's the side effect of the medication. It will fade away. So that's not something that you need to worry about. But if you have high creatinine and high potassium, that is worrisome. Then you have to start the treatment and stop the medication. Okay? So you have a patient, chronic kidney disease. What is the next step to protect the kidney and control the blood pressure? AC inhibitor. Once you start the AC inhibitor, what is the next step? I will check the creatinine and the potassium. What if you have creatinine mildly increased? It's okay as long as the potassium is normal. What if the potassium is high? Then in that case, I will reconsider my treatment. Good? So that is important to remember that after AC inhibitor, I have to check the creatinine and potassium. Not only just creatinine, the potassium is important. For getting the sick day holds, counseling and dehydration. Do not forget this one. We have the slide. It is coming. Remember, we had sick day. For the sick days, we have to hold certain medication that there is a mnemonic for it, which is called sad months. We will get into that. So do not forget about that. Missing referral. So this is another thing that they want to see if you miss it. So there are certain conditions that we need to know that now the patient is beyond my scope. Now I can't deal with this patient. I have to refer the patient. Let's say you have a patient. The patient has chronic kidney disease and the GFR is less than 30. So remember this. This is a must memorize point. So the GFR is less than 30. It is beyond my ability to deal with this patient. I have to refer it to a specialist. I let them deal with him. I cannot deal with this patient anymore. So this is the referral indication. The second one is albumin. If it is A3, A3 is the severe form of albuminuria, the severe form of kidney damage. Now it is beyond my ability. I have to refer it. And active segments, for example, if you see RBC cast or glomerulonephritis, in that case, I will refer. Remember, even if the patient GFR is normal, but you have albumin, urea, A3, still you refer. Still you refer. Even if it is more than 30, let's say it's 45. But if you notice out of all these three, this one is bold. And the reason I made it bold because it is one of the strongest indication than the rest. So if you have this one, that's an indication for referral. Okay. So basically everything you need to know about the chronic kidney disease is in this one slide. Now we will go in details in every single one of them, but if you know this slide, you know chronic kidney disease. But I will summarize it at the end again. All right. Now, chronic kidney diagnosis must prove chronicity, the definition of chronic kidney disease. If the GFR is less than 60 for more than 3 months, it is chronic kidney disease. Or the markers of the kidney damage, especially albuminuria, more than 3 months. Again, same thing. One-time low GFR can be acute kidney injury or transit. Confirm repeat testing. So how do I confirm it? By doing the same test in 3 months. I have to mention this. that I have to check it, and 3 months. So I'm checking the GFR in 3 months. If it is still high, then it's chronic. If not, it was just acute illness and it resolved. How to confirm chronicity? Repeat the GFR and urine ACR after recovery from the acute illness, which we did mention it. Look at the trends over time. We did mention it. Review the medication. This is also important. We cannot forget about this. So if you're dealing with any types of kidney disease or kidney illness, whether it is acute or chronic, so you cannot forget about these three. Non-steroid anti-inflammatory drug, which is a nephrotoxic medication, dehydration, which affect the functionality of the kidney, and obstruction, obviously, right? So we have to ask why, because let's say if non-steroid, the patient is taking non-steroid anti-inflammatory drug and he has kidney damage or kidney issue, it is only getting worse. So instead, we have to choose something else, like Tylenol. We have to switch it. MCQ one liner. Do not diagnose chronic kidney disease from a single mild low GFR. If it is one time, and it's mild, and there is no other albuminuria, nothing, and it's for a short period of time, less than 3 months, it is not a chronic kidney disease. So confirm it if it is more than 3 months persistent and assess albuminuria. All right. Who to screen in Canada plus initial test. So we don't screen everybody. We have to have a certain population who are at risk of chronic kidney disease and they might progress to failure. So only for those specific population we can do the screening, not for everybody else. And what are those population? Those with a diabetes mellitus, hypertension, those with a cardiovascular disease, family history of chronic kidney disease or kidney disease in general, relevant systemic illness or autoimmune disease. So first line is screening and monitoring test. As I mentioned before, we do the serum creatinine and GFR. Also, urine ACR preferred over the dipstick for albuminuria. Urine analysis if hematuria, infection symptoms, or suspected intrinsic disease. So these are the screening and monitoring tests. Do not screen everyone. Again, as I mentioned before, we don't do it for everybody. They have to be either diabetic, hypertensive, if they have a cardiovascular issue, they should have family history positive, and or systemic illness. So use the target approach based on risk factor. That's obvious. Now, this is the slide I need you guys to pay attention. It's easy, just remember it. I know it's hard to like just remember everything in one go or in one lecture, but I think if you remember the number three, it makes it much easier to memorize it. For example, if you're dealing with albumin, just remember three. Three, less than three is normal. 3 to 30 is moderate. More than 30 is severe. Okay? So three, remember the three. Three, less than three is normal. 3 to 30 is moderate. And if it is more than 30, then it is severe. So why ACR matters on MCQ1? Why? Albumin is, please mute yourself, whoever just joined. All right. Albuminuria is a marker of the kidney damage. Drives prognosis and cardiovascular risk. Change management. ACR, I already talked about these medication. So examples, diabetic protein can miss early albuminuria and varies with concentration. Persistent albuminuria A3 is a major referral triggers even if the GFR is more than 30. Remember, we had a few indication for referral, and one of them was if the GFR is less than 30. But remember, if you have A3 albuminuria here, if it is more than 30. So in some scenarios, they mention A3. In some scenarios, they may mention the ACR as more than 30. So if it is more than 30, or if it is A3, then you know that you have to refer the patient. It is out of your scope. You can't deal with this patient. This patient has to be referred. So again, they either mention A3 or they either mention more than 30. If the ACR is more than 30, I would just refer it regardless of the GFR. But GFR, if it is less than 30, it's again another indication for referral, or the glomerulonephritis, or persistent albuminuria. Okay. Now the CGA, what is CGA and what does it stands for, and uh, why is it important? So basically, it is used for staging. So C is the cause, G is the category and grading, or we can call it the GFR, because G stands for this GFR, for this one, or for grading. Okay, so C stands for cause, G stands for grading, categories, and GFR. And A stands for ACR, albumin creatinine ratio. So diabetic kidney disease, hypertensive, nephrosclerosis, glomerulonephritis, and etc. These are the causes when we are staging. So the category is based on the GFR. Now here, if you notice, G1, G2, G3A, G3B, G4, and G5. So based on this, I know how severe the patient is when I do this, based on GFR from G1 and G5. So if it is G1, it is more than 90. If it is G2, it is 60 to 89, which in these two cases, the patient would be normal, unless the patient has sign and symptom. So if the G1 and G2, if you see G1 and G2, it means the GFR is above 60. Up to G2, it means GFR is above 60. It is normal range, especially in adults. And also, if the patient does not have sign and symptom, everything is fine. You don't have to worry. But even if it is above 60 and the patient has symptoms like proteinuria and so on and so forth, that could be problematic, especially for elderly. But the problem starts when it drops less than 60. Here, G3A. This is the problem. This is the level when the problem starts. It drops less than 60. Now 45 to 59, less than 60. Now we are entering into the kidney damage zone. 3A, B, which is 30 to 44. And now G4, which is 15 to 29, very severe. This one, I would like you guys to remember that if you have this less than 50, then you have two options. Either dialysis or kidney replacement therapy. So just remember this number. If you have G5, which is equal to GFR less than 50, the next best step is obviously referral. And if you're a nephrologist, you need to decide whether you want to do the replacement or dialysis. So if you have replacement, that is the option. If you don't have it, look for dialysis. That would be your answer. Okay? So remember the G5 and GFR less than 15. Risk mindset, higher A category, lower G category, higher kidney risk failure and cardiovascular risk. So what it means that if you have higher A category means if you have A3, right? So if you have higher A category, it means if you have A3. What is A3? When the ACR is above 30. When the ACR is above 30, a severe form of kidney damage. So if you have that, it means the patient might go to failure. But if you have lower G category, by lower G category means if the GFR is low, less than 15, so it means the higher kidney failure and cardiovascular risk. Okay, this is how it is translated. Risk-based care. Use the kidney failure risk equation. This is actually, we will talk about this in detail. So basically, when you do this test or this risk-based care, if you do this, you would like to know the prognosis or chances of kidney failure in the next 2 to 5 years. Like this patient, in the next 2 to 5 years, what is the chances of the kidney failure? Okay. The track scope, rapid sustained decline is a referral trigger, persistent albuminuria, and also GFR or glomerulonephritis. I think we did talk about this other than rapid sustained decline. And this is a picture that helps us better understand it. All right, so the KFRE or kidney failure risk equation, Canadian risk tools. Again, quantifies absolute risk of kidney failure and chronic kidney disease, typically G3 to G5, G3 to G5, G3 to G5. So anywhere less than 60 up to 15. Okay. All right, we did this. Okay. Support referral and planning decision in Canadian pathways. Helps prioritize follow-up intensity. So these we covered, not very important. So high yield numbers. Many pathways use 5-year risk around 3 to 5 years. That's not important because they're not asking you percentage. Use alongside a GFR, ACR progression rate, and clinical red flag. We did mention this. Now for the OSCE. I will stage the chronic kidney disease using the CGA and estimate kidney failure risk using this to guide referral planning. You might get a question, and your answer to that question, like how do you go about a chronic kidney disease? And then you will say, I will stage it. Like, for example, if it asks you, like, how do you stage it and how do you predict the prognosis? You will say, I will stage the chronic kidney disease using the CGA and estimate the kidney failure using the KFRE or kidney failure risk equation to guide referral planning or to know the prognosis in the next 2 to 5 years. Risk is driven by albuminuria and trajectory, not GFR alone. So they really need you to know this, that you cannot diagnose the chronic kidney disease only based on the GFR. GFR is one aspect of the chronic kidney disease, but it's not the whole thing. You need albuminuria to be present for more than 3 months as well. Even if the GFR is normal, but albuminuria for more than 3 months is high, you have chronic kidney disease. Okay, so they really expect you to know this. Initial chronic kidney disease evaluation, primary care. So how do we go about it? Confirm, first of all, the baseline assessment is to confirm chronicity. How do I confirm it? If the lab test, which I initially had it 3 months ago, was abnormal, and now 3 months later, it is still abnormal. So now I confirm it. Okay. So you cannot have one abnormal GFR, for example, for 2 weeks or 3 weeks and call it chronic kidney disease. No, you have an abnormal 3 months later or more than 3 months later. If you still have abnormal or even if it got worse, then you have the chronic kidney disease. Review the diabetes mellitus, hypertension, systemic illness, medication, family history. Why? Because they are more candidate for the chronic kidney disease. So lab, electrolyte, creatinine, GFR, urine ACR, urine analysis, you need these for the NAC, OSCE, and MCQ 100%. You have to know it. Assess volume, status, and blood pressure, including the orthostatic symptomatic medication reconciliation and renal disease adjustment. When to add extra test? Renal ultrasound if obstruction is suspected, obviously, right? Active sediments RBC cast, cellular cast, urgent nephrology. Why? It shows glomerulonephritis. Why we refer it? Because the patient needs biopsy. We can't do the biopsy, so we have to refer it, right? Consider secondary cause when rapid decline or systemic clue present. Obvious, very common, so I'm not going to discuss this. So blood pressure control, highest yield intervention. I think I did mention that if you have chronic kidney disease, the priority for us is to protect the kidney and the heart by controlling the blood pressure, right? Accurate measurements, we know that. So this is very basic. Lifestyle, sodium reduction, activity, weight, smoking, cessation, they're all part of it. You have to remember it for the narcosis. Pharmacotherapy tailored to albumin and tolerance. So clinical, in terms of clinical, we need to use AC inhibitor or ARBC as a first line, which I did mention in the first slide. But a few things that I need to know when I'm using it, that what should I do next? As I mentioned before, I'm repeating because I saw a few IMGs just joined. If you are starting the AC inhibitor to protect the kidney and the heart and control the blood pressure, the next best step is to check the creatinine and potassium. If the creatinine goes up a little, or mildly, it is okay. It is the side effect of the medication. It will come back to normal. But if it increases, not only the creatinine, but the potassium is increasing too, in that case, you have to reconsider the treatment and take care of the potassium because it will affect the heart. Okay? And one more thing that we need to know that we should not combine the ACE inhibitor and ARBS. I think it's very obvious. Everybody knows it, but still I made it bold and red so that you don't have to make this mistake. And if your patient is taking ACE inhibitor, not improving, it doesn't mean that you have to add ARBS because it makes it worse. And especially one of the most common complications of chronic kidney disease among all others was hyperkalemia. Remember that that's the most commonly tested complication of chronic kidney disease in the licensing exam. And we will talk about it, how we go about it when we have it. So in MCQ1 phrasing, blood pressure control is one of the strongest intervention. So if you have chronic kidney disease, the strongest intervention or the best intervention to do to slow down the chronic kidney disease progression is to control the blood pressure. With what? With AC inhibitor or ARBS. Why? Because it not only controls my blood pressure or the patient's blood pressure, it protects the kidney and it protects the heart. I will individualize target based on the tolerance and orthostasis. Again, when you start it, remember the creatinine, remember the potassium, and remember that you do not have to combine those two medications, ACE inhibitor and ARBS. ACE inhibitor, ARBS must say monitoring. So again, I think I did mention this, recheck creatinine and potassium. And I told you that if you have creatinine mildly increased, don't worry about it. It will come back until the body starts to adjust to it, especially the kidney. But if the potassium is high, that's not going to come back to normal. You need to start the treatment. Expect a small creatinine rise, as I mentioned before. Assess volume status. Review always, if you're dealing with a kidney issue, always remember that you need to review these medication parts like dehydration, non-steroidal inflammatory drug, and salt substitute. Sorry. Counseling line, very important. This is the most important part for the NAC OSCE. If you're also attending, which most of you are attending the NAC OSCE, if you have vomiting, when you're counseling your patient who has chronic kidney disease, you're counseling, this is something that you cannot forget. If you forget this one, you will definitely lose a huge chunk of mark or score in that station. It will affect the overall mark. So if you're vomiting, if you have diarrhea, if you have dehydration, please temporarily hold the SAD mans. And what is the SAD man? I think I do have I do have it here. So this is the Sadman, Sadmans, Sadman. So S stands for sodium glucose co-transporter 2 inhibitor. This is the medication which is also used as a cardio and renal protector in someone that who has chronic kidney disease with diabetes and overweight or obesity. Okay, but if the patient has a sick day, like really severely sick, acutely sick, I have to stop this medication. AC inhibitor, again, if you're vomiting, you have diarrhea, you have acute illness, especially dehydration, you need to stop ACE inhibitor or ARBS. Diuretics, furosemide, metformin, that's another medication that you need to stop. ARBS and non-steroid anti-inflammatory drug and sulfonylurea. So these are the medication. If your patient has an acute illness, dehydration, they have to stop it right away until they feel better, and then they can resume their medication. All right. I think we missed this one. Yeah. So ACE inhibitor ARBS mass monitoring. I think we did talk about this. Okay. Sodium glucose co-transporter 2 inhibitor renal and cardiovascular protection, as I mentioned before. So same thing. If it happens that your patient has chronic kidney disease and the patient is not a good candidate for ACE inhibitor, or the patient is overweight, you want to control the weight, you want to protect the kidney, and you want to control the diabetes, which is also a strong intervention for somebody who has chronic kidney disease secondary to diabetes mellitus. So this would be the best option. But remember, if the patient is acutely sick, then you have to reconsider using this medication until the patient is good enough to take the medication again. Avoid progression and accelerators. So avoid non-steroid anti-inflammatory drug. I think I did mention all this. Renal dose adjustment, optimize diabetic smoking cessation, plant contrast, avoid non-steroid. Yeah, I did mention. Tell us before starting new over-the-counter medication or supplement. So this part is for narcolepsy very important, that if you're dealing with someone who has chronic kidney disease before discharging, you need to educate your patient that you have to avoid certain medication, and one of them is non-steroid anti-inflammatory drug. Why? Because it makes it worse. And also you have to let your patient know that tell us before starting a new medication, even if it is over-the-counter medication or supplement, because in some cases they might hurt your kidney, and we want to know if it is the right medication to start. And also we will adjust dose of the kidney clear medication. And if things gets worse, please come back immediately to emergency room. So these are the things that you need to educate your patient before discharging. Chronic kidney disease complication checklist. For the checklist, anemia of chronic kidney. So high yield complication. If you guys remember, I mentioned there are certain, but out of all of them, most commonly tested is, I'm not saying anemia is not there. I have seen anemia in a few question bank, but most likely they will be testing you on hyperkalemia. It doesn't mean that you have to ignore the rest. Learn about anemia. There are a few points that I have to mention that you need to know it, and if you don't know it, you will miss out in the real exam. So anemia of chronic kidney disease, iron deficiency assessment. So for chronic kidney disease, there are certain things that you need to do regardless. For example, check for anemia. You cannot ignore it. And check for the iron. You need to do that, especially if it is chronic kidney disease, because you need to start treatment with erythropoiesis, and you cannot start the erythropoiesis before having enough iron in the system. If you have iron deficiency, not only you're not helping the patient, it will make the condition worse. So you need to check the anemia and you need to check the iron before doing anything else, especially before starting the treatment. So calcium phosphate and parathyroid trend, parathyroid hormone. Why? Because if you have chronic kidney disease, the function will reverse, and there will be abnormalities in terms of the level of the potassium, also potassium, especially calcium and phosphate and vitamin D. So you have to check for the parathyroid hormone, calcium, phosphate. Metabolic acidosis, persistent low bicarbonate, hyperkalemia, diet and medication contributes. Again, for the hyperkalemia, we will talk about it in details. If hyperkalemia happens and you do not have severe signs and symptoms, obviously you go after the cause. What is the cause of this hyperkalemia? Is it the medication that I started? Is it ACE inhibitor? Or this is some sort of, for example, diet plan that the patient has. The patient is taking so much calcium. For example, if your patient is drinking, for example, coconut, or he drinks some sort of drink that has too much or it is very rich in potassium, then you have to change that and everything gets back to normal. But if it happens to be the medication that you prescribe, then you have to reconsider your prescription. Fluid overload and hypertension. So exam linkage, what they ask. Pick the correct first investigation. Example, iron studies before this. So remember that I made it red because before starting erythropoiesis, you have to check the iron. If the patient has iron deficiency, not only the erythropoiesis treatment will not help, it will worsen the condition. So choose the safest first step for the hyperkalemia. Medication, diet, review for a stable hyperkalemia. If your patient is hyperkalemic but stable. Obviously, if my patient has cardiac sign and symptom, for example, tall T, arrhythmia, then I would definitely start the calcium. Recognize when the complication become referral trigger. We did talk about this. So when to refer to nephrologist, this is memorized. You have to memorize it. You have no other choice. And it's not very hard, to be honest. It's not very hard. So the only thing you need to remember, the GFR, if it is less than 30, refer. It's out of your scope, refer it to the specialist. If you have persistent albuminuria and the ACR is more than 30 or more than 60, obviously anything above 30, refer. It is, or in some cases, they just mention A3. A3 or more than 30, refer. Rapid sustained decline, or the patient is having chronic kidney disease and rapidly getting worse. So it means it is you cannot do anything, just refer it to specialist. Or active segments, if you see the RBC cast, or if this is vasculitis or glomerulonephritis, refer, because the patient need biopsy. You can do that in your clinic. Refractory, hyperkalemia, acidosis, volume overload. Now, planning threshold. This one is very important. Please just remember it. If it is less than 30, refer. But if it is less than 15, dialysis or replacement. Again, if you have the patient, refer it, because that's not, you can't do anything. That's not your job. So you refer it. So you might get a case that your patient has less than 50. So what is the next best step? The next best step for me as a physician is referral. But for the specialist, the next best step is to do either dialysis or the kidney replacement. But if it asks you what is the best next step treatment, in that case, it's not asking you what is the next best step for you. He's asking you in general, your knowledge, that what do you think that will help the patient. So now I know as a physician that if it is less than 15, the patient has two options. Either the patient has to go through the transplant or the patient has to get a dialysis. And obviously the kidney failure risk equation alongside the threshold or period, we did talk about this. That we need to know the prognosis and the chances of the kidney failure in the next 2 to 5 years. So the kidney replacement therapy planning, avoid unplanned starts. So sustain less than 15 or high kidney failure risk equation. Early if rapid progression or heavy albuminuria. What planning includes modality education, hemodialysis, peritoneal dialysis, vascular access to peritoneal. Okay, these are two details, so they're not going to ask you. As long as you know that the patient needs dialysis, you should be good. So MCQ1 phrasing. Dialysis starts for symptoms or refractory complication, but planning starts early to avoid emergency initiation. Now, this part is more for the NAC OSCE. OSCE read the script, the chronic kidney disease consonant script. This is a long-term reduction in the kidney function. If they're asking you or you want to educate the patient, this is how you're doing it. So the condition that you have is a long reduction in kidney function. Our goal is to slow the progression and reduce the heart risk. The key steps is the blood pressure, check urine ACR, kidney protective medication when appropriate, avoid non-steroid anti-inflammatory drug, and adjust drugs doses. We will monitor potassium, bicarbonate, anemia, and bone mineral labs and refer if risk increases. So sick day holds, again, Sadman, we did talk about this. Rapid MCQ1 pattern maps. STEM, best answer. Diabetes, hypertension, how do you screen? Urine, ACR. Single mildly low GFR during illness, repeat in 3 months. So these are the questions that if you know most of the cases in real exam, you will answer it. For example, this could be one question. You have a patient and your patient has diabetes, and your patient has chronic kidney disease. For the screening, what do you do? Urine ACR. For example, you have a patient, the patient has low mild GFR during gastrointestinal illness. For confirming the chronic kidney disease, what is the next step? Repeated in 3 or more than 3 months. So albuminuric chronic kidney disease plus hypertension, what medication do you use? ACE inhibitor or ARBS? What next? I will monitor the creatinine and potassium. Eligible diabetic albuminuric chronic kidney disease. Consider what? I forgot to put the obesity. It doesn't have to have it, but it really helps with the obesity as well. So consider the sodium glucose co-transporter 2 plus make sure the patient knows to stop SATMANs on sick days. RBC CAS and activated segments, urgent nephrology. If GFR is less than 30 or heavy albuminuria, what do I have to do? Refer to nephrology. So safety, phrase, and score. I will recheck creatinine and potassium after starting or titering the medication, ACE inhibitor or ARBS. I will review the non-steroid and other nephrotoxic and renal dose adjust medication. I will consult on sick day holds during the dehydration. I will use the CGA and KFRE to guide follow-up and referral plan. And these are the checklists, the 10 checklists that they will test you if it is the NAC OSCE, or they will make question out of these 10 points in the licensing exam. So if you know these 10 points, you're good. You will definitely pass all the cases related to chronic kidney disease. What? Confirm chronicity, we have to remember the 3 months. We have to remember the 3 months, GFR less than 60, and albumin more than 3. In worst case scenario, 30, right? So state the CGA and track tragedy, trajectory. We did talk about it, the cause, the GFR, the albuminuria. Use the ACR, and the highest one is A3 or more than 30, which is the severe form. Optimize blood pressure with what? ACE inhibitor. But do not combine ARBS with the ACE inhibitor. So ACE inhibitor or ARBS for the albuminuric chronic kidney disease. But if you do it, what is the next step? I will check creatinine and potassium. What if the creatinine increases mildly? It's okay. How about if it increases, but the potassium increases at the same time? Now I would reconsider my treatment and take care of the potassium hyperkalemia. So when do we consider the sodium glucose co-transporter 2 inhibitor? If my patient is diabetic, chronic kidney disease, obesity, to protect the kidney and the heart. Avoid non-steroidal anti-inflammatory drug and other medication that hurts the kidney. Monitor for the complication. And what are the complications? Anemia, CKD, MBD, acidosis, hyperkalemia. All of them are important. Out of all of them, pay attention to anemia and hyperkalemia, that they are most commonly tested. Again, I'm not saying the rest is not important. They may ask you, but most commonly tested is hyperkalemia. The second one is anemia. The third one is the CKD, MBD, and acidosis. No referral triggers. We have already talked about it. If the GFR is less than 30, refer. Albumin A3 or ACR A3, refer. Rapidly decline, refer. Glomerulonephritis, refer. Plan for the kidney replacement therapy if it is less than 15, the GFR. So these are the summary. I think we covered everything. So we know the definition, we know the classification, we know the GFR, we know the albumin, we know the ACR, and we know who are the candidate, which are the diabetic, hypertensive, cardiovascular, family history, and systemic disease. They are the candidate, and how to go about them and how to treat, right? We have already discussed this. So in terms of chronic kidney disease, essential management monitoring plus referral, top three management is blood pressure. Not only blood pressure, we have to take care of the diabetes. But how do we take care of the blood pressure, which is the strongest intervention, is to use ACE inhibitor. This slows down the progression of the chronic kidney disease. Not only that, it protects the heart. The kidney protective medication, when indicated, again, the same thing. We start the ACE inhibitor, but we never combine it. And at the same time, when you start it, we have to check the creatinine and potassium. Avoid nephrotoxin like non-steroidal anti-inflammatory drug. Why? Because it makes the GFR worse. It goes down. The patient will have hypertension, edema, acute kidney injury, and worsen the hyperkalemia. Monitoring, we have already talked about this. This is basically everything that we discussed. I put it in one slide. All the discussion we had is in this slide. And the abbreviation, so the CKD, MBD is chronic kidney disease, mineral and bone disorder. The KFRE is kidney failure risk equation. The CGA cause GFR and albumin. The RAS is renin, angiotensin, aldosterone system. This is, the replacement and erythropoiesis is stimulating agent. And thank you very much.